Hello, my name is Professor Joy Lorne. I work at the London School of Hygiene and Tropical Medicine and also with Saving Newborn Lives, Save the Children and UKA, the Department for Development in England. And this presentation is about every newborn, an action plan to end preventable deaths. I'm speaking on behalf of a very large team because this is a large issue that's about to get a whole lot more attention. And when we think about what our delivery goal is around the world, we believe that no woman should die while giving life. And yet, in this year 2012, not long to go to the target of the Millennium Development Goals in 2015, there are still around 250,000 women who die every year while giving life. No newborn is born to die, and yet there are still 3 million who die. No baby should be stillborn, and yet 2.6 million babies die. And most shockingly, there are about 1.2 million women every year who go into labour with a live baby, whose baby dies before that baby is born. And in addition, after the first month of life, there are around 2.9 million children who die, many of whom are stunted and undernourished, and a lot of that undernutrition actually starts from in utero. And so if we look at this, it's a total of 10 million deaths that are happening every year, virtually all of them preventable. And notably, 3.5 million of those are happening at birth or within a few days of birth. And this is one of the grandest challenges that faces us at the end of the MDG era and the critical less than 1,000 days that we have left, but also into the future. And not only is this the most important time, riskiest time for deaths, but it's also a fundamentally important time for development, loss of development potential for babies who have complications at birth or are born too soon or born too small, have a disproportionate effect, especially in the poorest countries where those contributions are needed most for economic growth. And as we look at this, one of the fantastic changes that we've seen over the last decade since the Millennium Development Goals were set and have gained traction is that for Millennium Development Goal 5 around maternal mortality reduction, that the pace of change has really turned around. Even a few years ago, we were saying this was the most off-track Millennium Development Goal. And yet now, the maternal mortality ratio is being reduced at about 4.2% per year. It's not enough, and there are still preventable maternal deaths, especially in the poorest countries and particularly in Africa. But this is a big turnaround in progress. Then if we look at children after the first month of life, so for Millennium Development Goal 4, progress also has picked up. So over the time period of the Millennium Development Goals from the 1990 baseline, it's been around 2.5% per year. But since the year 2000, we've seen an increase in that progress because of great re-attention to child survival. Still not fast enough to hit the goal, but definitely moving much better. But in the middle, we have these two big groups of deaths. Newborn deaths in the first month of life only reducing at about 1.8% per year, and stillbirths only reducing at probably around 1% per year. The trend data is more limited. And so if we look at this critical time period around birth, not only is the burden large, but the progress for change is too slow. And the progress is too slow, especially for the poorest countries. So if we look at this graph with three bar charts, we can see that in the high-income countries, newborn deaths have been reduced by 50% still in this time period, and yet in the poorest countries, 30% or less. And in Africa particularly, this is a shocking statistic that during the time period of the Millennium Development Goals, when we've had a great revolution in reducing child deaths now to under 7 million per year, the only group of deaths that has increased is newborn deaths in Africa. And this is because of flatlining of the change for risk of newborn deaths, but it's also because of ongoing increases in births because of unmet need for family planning. And so all around the world, but particularly in Africa, we need to link the issues of newborn survival and family planning. And if we look at the rate of change in Africa, if we were to project forward this same rate of change and say, how long would it take until a baby born in Africa has the same chance of survival as a baby born in Washington or New York or London or Oslo? At current rates of progress, it would be more than 140 years. And as someone who was born in the bush in northern Uganda, someone who's an African, I think this is completely unacceptable. And for it to take almost 3 times as long for us to bring change for an African newborn as it took to bring that same change for babies in rich countries. So when the transition for neonatal mortality happened in rich countries, it took us around 30 years to make this same change. So to go so much slower when we actually have more technology that allows simpler care at a lower cost is unacceptable. And so the whole point of this Every Newborn plan is how we can change that so that every newborn, including newborns in Africa, would have that same chance, and that chance won't be waiting for a century and a half. So what I want to talk about is, why are these 3 million newborns still dying? Can we change? How much change do we want? How ambitious can we be? How realistic do we need to how realistically do we need to think as well in terms of actually making that happen? Where do we want to be in 2035? How can we do this? What is this plan and how will it make a difference? Who's involved? And especially, how does it interact in countries? Is this just another burden on countries, or is it a real country-driven opportunity for change? So there are 3 data-based reasons why change is possible now. First of all, we know the causes of newborn deaths. 10 years ago, we hardly knew the numbers. 5 years ago, we had a lot more clarity on the causes, and we know that the 3 main killers of newborn deaths in almost every country around the world are preterm birth, birth complications, and infections. These are visible. We have this data for every country of the world, and there's no excuse for saying these are just mystical. We know these solutions, and those solutions, we know these causes, and the causes also link to solutions. So if we look at the 3 main causes of newborn death, we have coined this idea of looking as 3 by 2. So it's a bit like the HIV momentum, and saying we would reach 3 million by the year 2005, so 3 by 5. This is the 3 by 2 for newborns. So first of all, looking at preterm birth and saying, what can we do to prevent? So management of preterm labour, what could we do more upstream? And then better care of these babies, both kangaroo mother care and essential newborn care. Birth complications or birth asphyxia, and also intrapartum stillbirths. Prevention through better obstetric care, especially quality of care and monitoring at labour. And then care through essential newborn care and resuscitation if needed. Newborn infections. Such a cost-effective approach is through prevention, both through looking at infections during pregnancy and then essential newborn care, particularly breastfeeding, and chlorhexidine cord care where appropriate. And then case management of neonatal sepsis, highly effective. And these items which are starred here are those that have been prioritised by the UN Commission on Life-Saving Commodities for Women and Children. But if we were put together all these 3 by 2 and reach every woman, reach every newborn, over 2/3 of newborn deaths would be preventable. And this is actionable now with the tools that we have in our hand, without having to have intensive care. It's not that we don't want to move to intensive care, but that shouldn't stop us moving now if we don't have it. And so if we look at the ingredients we need for this, for these interventions that have particularly high impact around the time of birth, if we look at case management of neonatal sepsis, we're talking about injections with antibiotics that are antibiotics we've had for decades. There isn't anything here that is complicated, except that we do need to be able to actually identify babies and empower workers to understand how to treat neonatal sepsis. Chlorhexidine umbilical cord cleansing is something that mothers can do at home that makes a difference. Antenatal corticosteroids for preterm labour, high impact and yet very little attention on the global agenda. Neonatal resuscitation and the devices. We've seen a real revolution in the last few years in terms of simplified approaches to neonatal resuscitation and the power of public-private partnerships, particularly with groups such as Laerdal, that have led to easier to use devices. And then kangaroo mother care, which doesn't involve any commodities and yet has such impact and is a great platform both for seeing that we can save preterm babies, but also for building out to improve those services. And so as we look at these high impact interventions, the question is, do they really make a difference? Is it feasible for them to get to scale? And over the last decade, we can see that 77 countries, including 13 that are low income, have made dramatic progress in reducing newborn deaths by at least a quarter. And most impressively, we have Rwanda, who has been reducing neonatal mortality rate at around 6.2% per year, one of the fastest progressing in the world and yet a low-income country. So understanding what these countries have done is critical to inform their neighbours. Just imagine if the rest of Africa was achieving that same rate, how different the trajectory would look for newborn survival in Africa. So moving on from why newborns are dying and these 3 reasons why we can change, where do we want to be in 2035? In this plan, in our vision setting, what are we aiming for? So this slide shows the important analysis done for a Promise Renewed, the call for action launch in Washington in June of 2012, and great momentum around countries. The aim to reach an under 5 mortality rate of 20 per 1,000. And looking at this graph, you can see that if we were to keep the under 5 trajectory as it is, the top line, that we would continue to still have an unacceptable number of child deaths. And yet, if we look at what the goal has been set at, the bending of the curve for under 5 deaths, coming down from currently almost 7 million child deaths, coming down to a target of 20 in 2035. That target will be almost the same as the level of neonatal mortality if we don't do something very different for neonatal mortality rate. Even taking the more recent change for neonatal mortality, speeding up and projecting that forward, it's still going to be almost all of the goal. So this underlines the fact that unless we really, really bend the curve for newborn survival, we will fail to meet the goal of ending preventable child deaths. However, what does that mean? If we were to take the same approach that was taken for the under 5 mortality target setting and take the level of OECD countries for under 5 mortality and to apply that for neonatal mortality. So neonatal mortality, apart from 2 OECD countries, all of them have an NMR of 5 or less. So if we were to say that every country in the world were to achieve a level of 5 or less for neonatal deaths by 2035, you can see from this slide that Africa and Asia both would have to make a dramatic change in the rate of progress. And so as we move forward with the discussions for this plan, the country consultations, the online consultations, we look to you in the audience and to those in countries to really feedback on how you think these targets should be set. Should we be the balance between ambition and realism, the balance between having the same target for everybody or looking at region or country-specific targets? So in contrast, if we were to take a relative target, which was how the MDGs worked, and to consider, for example, reducing neonatal mortality rate by 75% from 2011 by 2035, then this would still be requiring major change in sub-Saharan Africa and South Asia, but every country is having to go at about the same rate, about 5.7 per year, which is faster than they would have had to go, even forgetting the Millennium Development Goals. It is ambitious, but it's putting everybody at the same rate. So to wrap up this section on thinking about the Every Newborn Plan, just some thoughts about the target setting discussions. Should we have a universal target, change for all of the next generation to the same level, the principle that was applied in A Promise Renewed, or should we have relative targets? How ambitious should those targets be? And very important other considerations, stillbirths still not mentioned in many ways on the global agenda. In the post-MDG framing, more than 400 submissions on the future we want in the post-MDGs. Only one mentioned newborns and none mentioned stillbirths. Stillbirths do count. They count for women. And to make those count, maybe we need to consider a goal. This is certainly something that's come out of the discussions and consultations that's been had so far. Then considering the timeline, 2035 is very far away. Now the post-MDG framing has set its target around 2030. Should that be the right framing? And then clearly the need for interim targets which explicitly set out progress and milestones along the way, but also link with other initiatives, notably Family Planning 2020 and A Promise Renewed, amongst others. The principle of equity, reaching everybody, not just taking safety and averages, what happens at subnational level, especially in big countries. And then fourthly, the issue of preventable mortality and thinking beyond mortality, also considering development outcomes. So there are many analyses in progress that will be feeding into a series in the Lancet called Lancet Every Newborn. And your discussions and feedback are welcome on this. Moving on from the targets, clearly we know that we need to change. We know that we need to be ambitious, even for those countries where the baseline is high. We really need to look at doing things differently. But how is that going to happen? What are the actions and what's going to be done differently? So in this, we are looking at having very strategic areas of focus. And the first one and the most important one, and this one really is kind of the base of the pyramid for the whole plan, is very much the focus on care during labour, birth and the days after birth as the crucial time for saving the lives both of women, newborns, preventing stillbirths and also disability. The other parts are important and they form a very critical part of that pyramid. But without this and change in this area at birth, we will fail to reach our goal. And then here are a number of other areas of important focus. What to focus on? Well, change won't happen unless we pick the right things to do, but also reach high coverage for women and for children. And that will require looking at context-specific and intervention-specific bottlenecks so that we really can overcome them. It's not just about having policies. We need to look about what's stopping implementation and what very targeted actions need to be taken in different countries and maybe in different subnational areas, and looking at those. And some of those will be systems issues around not having enough people, enough midwives, enough workers, or not having enough commodities. But some of them will be very targeted to a given intervention in a given context. Thirdly, how? The important focus on quality. As we move forward with coverage, the huge shift of births now happening in facilities, we're failing to do the right thing for many of these women and babies who are delivering in facilities. And this requires strategic use of data, investment and innovation to really make effective care at birth and maternal and newborn care around this time. And skilled workers and leaders with use of data are critical to this change. Fourthly, who are we focusing on? And clearly anybody who thinks that we're going to change outcomes for every newborn by only starting once we have a newborn is going to miss the plot in this one. This is about every girl, every woman, every newborn, especially focusing on the poorest. But we can take the outcome for the newborn as a marker for all the others because the newborn is the most vulnerable. A baby can die within minutes. And a health system that can respond to a sick baby is a health system that is effective. And then fifthly, people power. This isn't something that can come just from the top down. One of the problems for newborn deaths is that it's still accepted that newborns will die. In the last few years, we've really seen society change, and I see this clearly around Africa. African Union leaders and heads of state who say that it is unacceptable for women to die giving birth. But we have yet to hear people say that it's unacceptable for a newborn to be born and to die needlessly. And this is something that families, communities, parliamentarians and society can mobilise change for, and can also mobilise change for the things that they can do very powerfully to save the lives of mothers and of babies. Sixthly, counting. And this is one of the critical areas, really, where the newborn has lost out. If you can't count every birth, if you can't count those deaths, stillbirths and newborn deaths, we aren't counting a lot of the critical coverage areas, then accountability is lacking, and also programme improvement is lacking. We need to count and use that data. And then finally, action by all, leadership, political will and financing. So these are the areas of the plan. The plan itself will be quite short and quite high level, but each of these areas need to be translated. The plan is only part of the process. It's really action with a plan, and these actions are the ones that will make a difference. And I'm not going to talk through all the actions, but I just want to underline again this very important priority given to care during labour, birth and the first days of life, because this brings a triple return on investment. Around 1 million babies dying on their birthday is something that should not be acceptable or left. And so what is the plan? Well, just to say before I move on to what is the plan, how can you input to shape these directions? We've just given here the areas of focus, but how can you input to shape those? Please do go to this website, the globalnewbornaction.org website, and give your ideas for what you think needs to be done, examples of how to do it and critical inputs. So what is this plan? Well, the plan really draws from a movement towards action, and the plan is really just part of that action. There have been a lot of important moments over the last few years that have started to put newborns on the agenda. The Lancet Newborn Series in 2005, momentum in countries, particularly with some of the work that the Bill and Melinda Gates Foundation has funded through Saving Newborn Lives. The call to action last year was a pivotal moment. The launch of the Born Too Soon report, then also linking with World Prematurity Day, and parents really mobilising, parents' voice and the voice of governments making new commitments, like this commitment in Uganda that was made by the Minister of Health. Opportunities with the UN Commodities Commission, very dynamic meeting earlier this year in April in South Africa with 40 countries represented, and real demand from countries to see change and to see action, and also to see the global community more cohesive in what is being said about this issue. The launch of State of the World's Mothers 2013 with a focus on the first day of life, resulting in more than 2 billion media coverage around the world, has really caused momentum in many, many high-burden countries. And as we move forward, looking towards the launch next year of this action plan, each of these points has had a pivotal part to play in shaping every newborn. And so the plan, we can say we have so many plans, why have another plan? What is every newborn? Every newborn hooks very closely to the UN Secretary General's plan for every woman, every child, really underlining all the principles that are in that and adding a critical gap in the continuum of care for this large problem that also has huge potential for change. And the main point we would like to highlight here is that every newborn comes from the country up to global level. Many global strategies start at the global level and come down. This is one where the momentum for country change, the demand for country change has been building over the last 5 years. And the goal here is country-driven processes sharpening their plans, but also at the same time the global community becoming much more harmonised in terms of what is being said about this neglected issue. And so what is the Every Newborn Action Plan? It is a roadmap for change. It will bring together, both at global level but also at national level, some of the areas of action that sit within reproductive health, the importance of family planning, within pregnancy care, and then particularly at birth and that critical early postnatal period. Will be supported by evidence, by analysis that will be published linked in the Lancet around this time. And who's involved? Well, this plan, as I've said, really links to every woman, every child, the UN Secretary General and the fantastic momentum that has come from that global strategy. Also to a promise renewed, which has revitalised the energy in countries, the movement for addressing preventable maternal deaths also. The Born Too Soon report and the parent groups that are mobilising around the rights for their children, including those who are born too soon. And then many stakeholders, country governments, the UN, NGOs, universities, professional organisations, and all the different constituencies within the Partnership for Maternal, Newborn and Child Health. So the Partnership for Maternal, Newborn and Child Health has provided a critical platform in bringing together these different groups and their voices. So in the process, before the launch next year, linked to the World Health Assembly, we will be having country consultations that have already started. But the key point, both before and after that, is national action by professionals, parents and policymakers and all of us. So at global level, this fits closing a key gap within strategies between the fantastic increased attention to family planning, which is so important for women and for child survival, to a promise renewed, and in between to link every newborn. That these global actions and plans are all important and need to come together and not pull countries in different directions. And the different global actors who are also involved and the accountability framework within which we all sit needs to work together instead of pulling people apart. But yet if we go from this nice, beautiful figure at global level to look at what's happening at country level, the impression for many in countries is that initiatives land and proliferate and many come and not all result in huge change in countries. So how does this all fit together? This is just one example of Uganda, the first country to have the country consultation for the Every Newborn Plan. And looking at what has happened there just over the last few weeks is that, in fact, by bringing in the systems bottleneck analysis and the discussion across the whole continuum of care and looking at this ending preventable newborn deaths has resulted in being able to have a sharpened and strategic and integrated plan by pulling together the reproductive, the maternal and the child, with the newborn actually being a kind of wedge and entry point that covered all of those and actually brought together the agenda for people. So actually it's been an opportunity to harmonise action within Uganda. So not a separate process, but really sharpening the potential for mortality impact in this country. And this process of country consultation is now moving forward across a number of countries, allows I'm sure a different process in each country with different people at the table, but it really should be broader than just the normal process, but including NGOs and academics and parent groups and parliamentarians, so that this really results in a movement for change. And the analysis that is ongoing is also being supported by regional workshops in West Africa, one that happened in July, really led by the UNICEF office, and an upcoming one in Asia, with India, who accounts for 1 in 3 of every newborn death around the world, more than 800,000 newborn deaths, has really taken a leadership role in moving forward with process in high burden districts linked to their RMNCH+A process, really sharpening what can be done to save newborn lives. Online at the website you will find this toolkit, which will give you more details on what is included, a draft outline for the plan that you can feedback on, more PowerPoints like this one, the tools for assessment, country fact sheets, libraries on newborn health, and you can also find more information on the Healthy Newborn Network. So, in conclusion, every newborn is an opportunity for our generation to be part of ending preventable deaths, changing the next generation. We can all be a part of this. What are you going to do? Thank you.